Welcome to the GI Hepatology Academy, presented by Harvard Medical School. My name is Dr. Thomas Lamont, and you are tuned into the live session called A New Era in the Management of Hepatitis C with Dr. Nizam Afdal. Dr. Afdal is Chief of Hepatology and Director of the Liver Center at Beth Israel Deaconess Medical Center in Boston. He is also Professor of Medicine at Harvard Medical School. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Afdal.
Thank you for the introduction, Tom. So there are a lot of exciting changes taking place in chronic hepatitis C in the United States today, and I'm going to run through some of these with you this afternoon. We all know that hepatitis C is a global infection, with about 130 to 170 million people living with chronic HCV today. That's almost 2 to 3% of the world's population. There's very different prevalence in different parts of the world, with the highest prevalence being in certain areas of the Middle East like Egypt. But here in the United States, somewhere around 2% of the population is infected with chronic HCV. The epidemiology of HCV suggests that many of these infections took place almost 30 or 40 years ago. When we look at the global burden of hepatitis C, we recognize that there are significant barriers. These barriers are associated with our ability to test for hepatitis C, to care for these patients, and to treat them. In developed countries such as in the US and major parts of Western Europe, still most hepatitis C infected patients are unaware of their infection. There's an inadequate knowledge and awareness of HCV amongst healthcare providers and specifically amongst their patients. There are certain significant issues related to cost of care for hepatitis C, and there is overall a lack of any HCV screening policies either here in the US or the majority of Western countries. For our colleagues in developing countries, the same problems apply, but they also have issues with the fact that low political, provider, and community awareness of HCV as a significant health threat causes another barrier to diagnosing patients with hepatitis C. And 1/3 of the WHO member countries do not even collect prevalence data for viral hepatitis. We have in the past recommended screening for patients with high risk of having HCV infection. These include patients who have ever been exposed to intravenous drug use even once, patients who had blood transfusions prior to 1991. And with this, our guidelines have not been particularly effective. We still have not recognized anywhere near 50% of the patients who have hepatitis C. In a second look at the NHANES data, the Centers for Disease Control reevaluated the population and saw that baby boomers represented more than 75% of American adults with hepatitis C. As you all know, baby boomers are people born between 1945 and 1965. This population represents about 2.1 million people who have been exposed to hepatitis C, and up to 1.5 million of these baby boomers are unaware of their infection. One time, HCV antibody testing could identify up to 800,000 of them if this was used as an effective screening policy by our public health service. The CDC felt that not only was this population enriched with hepatitis C, such that actually the prevalence goes up from around 1.8% to 3.5%, but they also recognized that these are the patients in whom the HCV has been present long enough to cause significant liver disease. So amongst this baby boomer population, we also anticipate that many of these patients will have significant liver disease, including advanced fibrosis and even cirrhosis. These are the patients who are at risk of developing hepatocellular carcinoma and liver failure. There is a significant low level of awareness amongst these patients that they have been exposed, most of them more than 25 years ago, to hepatitis C. So clearly, an initiative to identify these patients would have a major impact on their health and their future outcomes. The CDC has therefore suggested that we test all adults born between 1945 and 1965 with a once-off single test for HCV antibody without any prior ascertainment of HCV risk. So it would be pure age-related screening. The beauty of this is that it also removes some of the stigma associated with hepatitis C. Many of our patients worry that if they tell us that 25 or 30 years ago they used intravenous drugs, we might look at them in a different way. However, clearly, if we just do it based on the fact that the prevalence in this cohort of patients is high, as is the presence of clinical liver disease, we will be able to perform screening without any of the stigma associated with hepatitis C. Now, screening is only effective if there is good linkage to both education and care. So why should we identify our patients with hepatitis C? Well, one of the simplest reasons to identify them is to make sure that they actually remove other risk factors from their health care. So one of the big risk factors is alcohol use. So even if you just identified patients and gave them education about alcohol screening and intervention, that would have an impact. Other things that cause progression of disease are the presence of obesity and diabetes, and it's clearly important to help patients understand that these are second hits that can cause more progression in conjunction with their hepatitis C. It's important, obviously, to educate the patients once they're screened as to the risks of infection of others, particularly the risk associated with bloodborne transmission from the sharing of things like razor blades, from the sharing of toothbrushes, from inadvertent blood spills that can occur from cutting your finger, etc., and also to refer them on to appropriate specialists for consideration of further evaluation and treatment. So this linkage to care is a critical part of the screening program. The CDC also looked at the cost effectiveness of a birth cohort screening program, and they looked at the cost per quality associated life years gained in the birth cohort screening strategy, utilizing the current standard of care of treatment, which is interferon, ribavirin, and for genotype 1 patients, a protease inhibitor. And they showed that overall, the cost was very much in line with other things that we screen for, with a cost estimated between $15,700 and $35,700, depending on which treatment and the duration of treatment that was chosen. So there's also a good rationale from that perspective. Now, it's very easy to say, let's screen all these people. There are a lot of people born in the baby boomer generation, almost 30 million people. And so screening all those, even though it's only a one-time, relatively inexpensive antibody test, we have to have the ability to take a policy like that and to put it into actual practice and clinical care. And this is a significant role for the primary care physician and for the internal medicine physician. So action plans have been developed by the DHHS for viral hepatitis. These include increasing the number of patients that we screen significantly and reducing the number of new infections. Now I'll just turn aside for a second here and talk a little bit about new infections. It turns out that the CDC on the Sentinel counties data estimated that we were getting somewhere around 19 to 20,000 new infections of HCV per year, much down from the peak where it was around 200,000 infections in the 70s and 80s. But one of the problems here is that this is not well recorded data. And here in Massachusetts, where our public health department has been very proactive in the area of hepatitis C, we have shown significantly higher rates of new infection than the CDC reported in the Sentinel counties. And this data on new cases has to be re-examined in the light of some of the behavioral issues that are taking place in younger people today. What is also needed is to remove barriers to HCV testing and referral. This barrier is quite significant. Many patients now require advanced specialists used to using interferon-based therapies to treat hepatitis C, but this is changing, and that's a really good change that's taking place. And we're looking forward to overcoming some of these barriers.
Can I ask you a question at this point from Dr. Linda Hunt? If someone screens positive for Hep C, what additional tests would the GI specialist like done before the referral, for example, titer, ultrasound, viral load, et cetera. Do you want to comment on that?
Yeah, that's an excellent question. So if somebody tests positive for hepatitis C antibody, 75% of those patients will have hepatitis C, but 25% will actually have cleared it on their own, spontaneous clearance. And so the next test that's required is really an HCV RNA test, which tells you is there active virus present. If there is active virus present, that person has hepatitis C. And one should also perform a genotype test. The genotype test tells you which type of hepatitis C virus there is between types 1 to type 6, because they affect the treatment choices. That simple regimen in a primary care situation is actually adequate prior to referral. For those of you that want to be excellent internists, if you also want to do an ultrasound, or you also want to do liver function tests and perhaps a serum marker of liver fibrosis, then those tests are useful. But I think that really the key that I would want to know is, does he have virus and what is his genotype? So there are big pushes forward to improve community awareness. That's in our communities that are high risk. These include communities where HCV is clustered. This is amongst methadone clinics. This is in areas where there are more homeless, where there are more people that might have been exposed. To improve the testing care, strengthen our surveillance systems in the public health situation, prevention for injection drug users with sterilized needles, which is used significantly throughout Europe. Obviously, a vaccine would be very nice, and there are some movement toward an HCV vaccine, but I still believe it's quite far away. And we still have a significant transmission of HCV in healthcare settings, and this obviously in a developed country has to stop completely. Now, we got a question of what tests would we like to do, but sometimes primary care doctors might turn around and say, well, why should we screen for hepatitis C? You know, lots of people have hepatitis C, and many of them don't die of hepatitis C-related disease. In fact, if you follow a cohort of patients with hepatitis C, maybe only about 15% will run into significant morbidity and mortality from hepatitis C. And so one of the questions that is always asked to us is, what is the benefit of identifying somebody with hepatitis C? And it's only recently that we've gotten some very good epidemiological data that tells us what that benefit is. And this was in a very large Taiwanese study called the REVEAL-C study, which took almost 89,000 residents of a variety of townships in Taiwan and ended up screening about 30,000 of them for hepatitis C. And they had no hepatitis C in the majority, but about 1,100 patients had HCV. And they followed these patients over time, almost for 17 years. And they looked at clinical outcomes. So the most important outcome, what happens to the patient. And what they showed is really shown on this plot, which looks at the hazard ratio for outcomes. And you can see that our HCV positive patients had a markedly increased relative risk of liver cancer, of liver cirrhosis, of liver failure, but they also had increased levels of nephritis, nephrotic syndrome, renal disease, and even an increase in extrahepatic disease, and overall almost a 1.7-fold increase in all-cause mortality. Hepatitis C is a systemic inflammatory disease. Not only does it affect liver-related outcomes, but it can also affect other health-related and quality of life-based outcomes. And you can see here showing those with hepatitis C in red, showing the hepatic disease-related mortality, which is obviously markedly increased, but also a significant increase in time over extrahepatic disease-related mortality. So hepatitis C has a significant clinical impact on our patients.
A question here from Dr. Benny Mullins. He says, can we wait until better therapy is available, put off the screening because it looks like every year or every month really better treatments are coming out? How about waiting for a couple of years and doing better?
I like that question, Dr. Mullins. So the issue here is that treatment is changing, and we're actually going to focus a little bit on some of these exceptional changes that are occurring in treatment a little later on in this talk. But one also has to be aware that many of our patients with hepatitis C are doing other things that can damage their liver, things that are occult. And the CDC has said, yes, we know better things are coming, but why don't we just identify these patients, advise them about alcohol, about other health-related issues, so that they don't continue to damage their livers while they're waiting for these new therapies. And as I'm going to show you, these new therapies are just about around the corner. So there's some very exciting stuff happening. Now, the question that was asked was a good one. Why do we wait for better treatments? And one of the things that we need our physicians to know is the treatment affects outcome. So everybody wants to know, well, if you get rid of hepatitis C, that's probably a good thing, but does it really affect the patient? So we now have data from clinical trials following patients who have advanced liver disease with significant fibrosis and cirrhosis over up to 10 years, showing that SVR, or cure of hepatitis C, prevents liver-related death. I'll take a moment here to explain the jargon of SVR. SVR represents sustained virological response. And what we know now today is these patients who have an SVR are actually cured of hepatitis C. You might say, how do we know they're cured? Well, we cannot detect the virus in the blood. We cannot detect the virus in the liver. We do liver biopsies and actually do PCR to detect the virus there. And we can detect down to as low as 10 viral particles. And most importantly, there is reversal of liver injury, and as I show you on this graph, reversal of liver-related risk of death. So, you know, cure is a word that we use in cancer, but we can also use it for this particular virus, and we do cure our patients of hepatitis C. And here you see that mortality-related overall long-term survival in patients who have SVR compared to those who don't have SVR. SVR is not a surrogate, it actually reduces overall mortality. Now, this would be great if we treated everybody, but you know, even now in the US today, many patients are not treated because of some of their comorbidities and the toxicities of some of the interferon-related treatments. But this graph is to show you that even if you increase the proportion of the population treated, that's going to have as much of an impact on mortality by treating more people than necessarily what the SVR rate is. So here's where we are today. We treat about 10% of people. We reduce the mortality a little bit. But if we treated more people, and for example, if we treated all people, we would significantly reduce the overall mortality. So treatment uptake is very, very important. And as I'm going to show you, we're approaching cure rates above the 80% mark, which is really quite fantastic. And the other thing is that treatment's only effective for those that receive it. Of all the countries that have this type of data about case finding, the country which really shows the most active screening programs is France. And in France, they find more patients with hepatitis C, treat more people, and they have a significantly improved reduction in cumulative incidence of death from hepatitis C. So we are a little behind in our case finding and in our making those patients move forward to treatment. Now, having said that, and putting a lot of pressure on people to think about screening for hepatitis C, what we really need to know is how is treatment improving and what's happening with treatment. So treatment started for hepatitis C even before the virus was identified in the late 1980s, and that was using interferon-based therapy. And we're still today using predominantly interferon-based therapy. And interferons are injectable agents that are potent cytokines that cause increased innate immune responses to clear hepatitis C. But you can see that over a period of 20 years, with respect to our ability to cure patients, we've gone from a low of 6% when we were using just interferon alone to as high as 70 to 75% now in the era of interferon, ribavirin, and direct-acting antiviral agents. So this is a pretty remarkable 20 years, but it's going to get even a little bit more interesting than that. We know which patients are easy to treat. We know which patients are hard to treat. We have a tremendous experience with interferon-based therapies. We understand the role of genotype, viral factors, patient factors, which are very important for interferon response. For example, African Americans do less well than Caucasians. Patients that are obese and older do less well. Those with more advanced disease, such as cirrhosis, do less well. And there are genetic factors that predict responses to interferon. One of the major advances in pharmacogenomics of any treatment was the identification of the IL-28B gene polymorphisms and their association with response to interferon. So we know a lot about who responds to interferon. And this has helped us identify the right patients to treat today. This is just looking at our genotype 1 patients, showing you that when we add in a new direct-acting antiviral, such as boceprevir or telaprevir, we get a marked improved response in our cure rates up to almost 75%. But this is not an easy treatment. Many patients will tell you that their treatment period with interferon was one of the hardest treatments they've ever undergone. They get a lot of side effects, and there is some significant toxicity associated with all of the components of the regimen, the interferon, the ribavirin, and the direct-acting antivirals, boceprevir and telaprevir. So it's not that we can't treat patients with this regimen, it's not that they don't work, it's just that we would rather have something somewhat safer and perhaps even a little more efficacious to treat our patients with in the future. The adverse events that are really, we have a lot of problems with are anemia, neutropenia, dysgeusia, and interferon side effects that are also significant. Now, I showed you a graph that showed progress. And that was progress in terms of cure rates. So on one hand, we have efficacy. On the other hand, we have tolerability. So when we look at this, this is where we are today. We have pretty efficacious treatments that have gone up quite a lot, but we don't have anything perfect. Nothing that's 100% efficacious with very high tolerability. And as we've improved our treatments, we've increased efficacy, but actually we've reduced tolerability. So treatment with pegylated interferon, ribavirin, and boceprevir and telaprevir is actually harder than just treatment with pegylated interferon, ribavirin. Patients get more side effects. It's less tolerable. And as we go on and introduce newer drugs, we still have to deal with the side effects of interferon, ribavirin. And eventually, we'll get into this area of interferon-free combinations. And one of these interferon-free combinations will end up with very high efficacy and very high tolerability, or some of them. And that's what we're working towards, so that as our last question, the person who asked the last question says, why don't we wait to get one of these so-called perfect drug regimens? So, what would it be? It would be one pill once a day with no adverse events and a cure rate around 100%. So obviously that is perfection. Can we get there? We might be able to get very close to that, but the progress is not necessarily linear in terms of all of a sudden it's going to appear. It's going to be stepwise. So now I want to turn to a series of recently published papers from the New England Journal of Medicine, and these are very important papers that highlight the wave of the future. So we have interferon and ribavirin, and we are going to add newer type drugs to interferon and ribavirin. These are what we call second generation direct acting antivirals. So they're new drugs that inhibit hepatitis C, and they have different families or different classes. And the hepatitis C virus has multiple targets. It has a protease inhibitor, it has a nucleoside polymerase domain which can be inhibited, and there is a replication complex for which NS5A inhibitors can target. So we have multiple targets. And because we have these targets, we can look at combining different drugs together to target the virus at different points. And obviously, just as you know with HIV, the goal behind that is if you target multiple points, you will prevent the emergence of resistance and then potentially be able to eradicate hepatitis C. If we want to do better than today, what do we want to do? Well, one thing we'd like to do is shorten the duration of therapy. You know, it's hard to talk to a patient and say, I'm going to start you on treatment and you probably will require a year of interferon therapy. The patient may be working, 55, 60 years old. That's a long period of someone's life to be on treatment and not know at the end of treatment whether they're going to be cured. So anything that can shorten that duration of therapy would be very good. So we want to do that. We want to improve tolerability and side effects, and we want to cure at least 80% of the people, probably higher if we can.
Apropos of that, Dr. Arthur Avalon states, I was involved in the Novartis Elisiprovir clinical trial, which was stopped by the FDA. His question regards resistance mutation, and he'd like to know if there are any such mutations in this current crop of DAAs.
So we're going to get to that, but it's a great question. I actually headed the safety committee for alisporivir. And so alisporivir was a very interesting agent because it's a host modifying factor. And it actually it has very little resistance associated with it. So it was a great drug. There were, as you know, some cases of pancreatitis. It was stopped and put on clinical hold by the FDA. And actually, as I understand it, the FDA are now looking to see if they can take it off clinical hold as the questions have been answered. But we're going to get to some of the resistance issues because resistance is important. With the protease inhibitors available today, boceprevir and telaprevir, there's a low barrier to resistance, and you do get resistance. But I'm going to address your question in some detail in a minute. So this is the first of the papers that was published in the New England Journal of Medicine looking at a polymerase inhibitor, sofosbuvir. And this is in combination with PEG and ribavirin. What is beautiful about this study is that it is just 12 weeks of treatment. You give everybody 12 weeks of PEG interferon, ribavirin and sofosbuvir. The sofosbuvir is 1 tablet once a day. And then you follow them to see if they're cured or not. There's no response-guided therapy. There's no waiting to see how people do. You just treat them. And these are the results given as the overall SVR results. You can see 90% of patients were cured with 12 weeks of treatment. That is an enormous increase in SVR rate. For genotype 1, it was 89%. For genotypes 4, 5, and 6, 97%. For patients with cirrhosis, the hardest to treat group of patients, we had an 80% SVR. No patient in this study developed resistance. Every patient in this study became negative on treatment, and the problem was the 10% of patients in whom the virus came back. So you have some relapse that takes place. The addition of sofosbuvir had no additional side effect profile. So here is a really, really fantastic regimen that still involves interferon, but is highly efficacious. This has gone to the FDA for a new drug application, and we will hear sometime in November whether this will be approved, and it represents a significant improvement in the treatment paradigm for our patients with genotype 1, 4, 5, and 6 hepatitis C. But it's not enough to have interferon-based therapies. So what we want is all oral therapies. And this is to address the question of our last speaker, and it's to talk about what these all oral therapies look like and how they might be used. And in fact, lots of phase 3 studies are underway, some have been completed, and there are actually some applications for approval of these drugs underway. So the drugs that we have fall into 4 big categories. And then the cyclophilin inhibitors such as alisporivir, which is a host modifying factor. But let's look at the 4 primary categories. We have the protease inhibitors, and they have a very high efficacy. They attack the hep C virus very aggressively, drop the viral load by 4 logs or so, but they're highly genotype dependent. So they work very well in genotype 1, less well in other genotypes. And they have a very low barrier to resistance. If you give a patient a protease inhibitor, within 3 days they will develop resistance. So by themselves, they don't have a strong barrier. The NS5As have almost the exact profile. High efficacy, they drop the virus by 4 logs or so, highly genotype specific, and again, a low barrier to resistance. The NS5Bs, of which sofosbuvir, which I showed you is one, have, again, very high efficacy. It's about a 4 log reduction, completely genotype independent. It suppresses all genotypes of hepatitis C because it is a chain terminator of the NS5B polymerase, and every single genotype that we're aware of is susceptible to this virus, and it has a huge barrier to resistance. In the current clinical trials program, with over 3,000 patients having been treated with sofosbuvir, there's only 1 patient who has developed resistance out of 3,000. And so for an antiviral agent, this has a tremendous barrier to resistance. And finally, there are the NS5B, the non-nucleosides, which are low efficacy, very genotype specific, and very low barrier to resistance. So you might think these are useless drugs. But when you have 4 different drugs, what you have is multiple opportunities. And these opportunities enable us to combine these drugs to really see what you can do for our patients. These therapies are changing, and the biggest change in these therapies are newer drugs are coming with more genotype independency and better barriers to resistance, particularly with respect to the proteases, the NS5As. They're a little bit away, but I'm now going to focus on how these combination therapies can be put together and the timelines for some of these. This is a very complicated looking slide, but I'm going to use this jigsaw puzzle a lot. And the jigsaw puzzle is the different types of agents being combined together. And there are multiple combinations going through advanced clinical trials. And I think it's relatively fair to say that in the US, by 2015-16, there will be multiple regimens that have the ability to cure patients with all genotypes of HCV. And I'm going to show you some of this data now. So the timeline is over the next 2 to 3 years, but some of these agents will actually be available for use as all oral treatments at the end of this year and early next year. This is one of the most complicated regimens, and I'm only showing this to you because it shows how powerful these regimens are. This is what we call a 4-drug regimen. So this is the max. If you want to think of our choices, we have 2 drugs, 3 drugs, 4 drugs. This is our 4-drug max regimen. It's based on a ritonavir-boosted protease inhibitor, ABT450, combined with a non-nuke and an NS5A with and without ribavirin. And the study design was to compare 8 weeks, 12 weeks, and 24 weeks of treatment with different regimens. And I'm going to just focus on 2 aspects of this results graph. There's a large number of patients in phase 2, almost 100 patients in each arm. And the first arm I want you to look at is the arm on the far right of the first set of bars, which is the 4-drug regimen, 12 weeks, 97.4% cure rate in treatment-naive patients, 97.4. And then look at people who'd failed interferon previously and had had no response to interferon. That same 4-drug regimen in the pinky purple on the far right, 93% cure rate. These are exceptional cure rates with all oral treatments. Now go all the way over to the left-hand side and look at the pale blue group. That's 8 weeks of treatment with 4 drugs, 88% cure rate. If you were to tell patients that cure rates between 88 and 98% can be achieved with as little as 8 to 12 weeks of multiple drugs, they would be very, very excited at these opportunities. And these results have been moved forward into very large phase 3 programs which are ongoing, and this type of regimen is anticipated to complete next year with potential for approval in end 2014, early 2015. That was 4 drugs. What could you do with 3 drugs? Okay, let's look at 3. This is a 3-drug regimen, and this 3-drug regimen used sofosbuvir, high barrier to resistance, with a drug called cimeprevir, which is a protease inhibitor. Both of these drugs will be approved by the FDA by the end of this year, probably, with and without ribavirin. These were people who had previously failed interferon, had no response to interferon, and they were treated for 12 weeks with and without ribavirin. All right? This is just the top-level results of the cure rates. You can see that over 90% of patients were cured with 12 weeks. Actually, the ribavirin made no difference. So this is 1 tablet of sofosbuvir, 1 tablet of cimeprevir for 12 weeks, no side effects, nothing above placebo, and you're looking at cure rates of 90% plus. So again, remarkable results, and this is being replicated now in patients that are also naive to treatment. So we've seen it in people who failed interferon and people who are naive to treatment. The numbers are small, but these are exciting results for our patients.
Any long-term follow-up on this data set?
So this is SVR 12, so this is 12 weeks in, but all of the patients that we treat now actually go into what are called registries. And we follow them for up to 3 years to make sure that these responses are sustained, because we want to make sure that our patients truly are cured, all right? So what about 2-drug regimens? Here's an NS5A inhibitor with a nucleoside inhibitor. This is an incredibly busy slide. You'd only need to look at one part of it, and that part is the cure rate. It's actually 100%. So it didn't matter which of these arms you were in, whether you got ribavirin or no ribavirin. It didn't matter whether you got 12 weeks or 24 weeks. The overall cure rate for genotype 1 and genotype 2 was 100%. So this is again amazing results. And the only reason that you can get these results is that these drugs are so powerful, they prevent resistance, they prevent breakthrough. Hepatitis C is a virus that if it's not replicating, it just dies. And so suppression of virus is now being shown to have these incredibly high cure rates. So again, our patients are aware of this and very excited about these concepts that these treatments are going to be as simple as this. So essentially, this is again 2 tablets once a day. Interestingly enough, sofosbuvir plus another tablet called ledipasvir have actually been combined into 1 tablet. And so that perfect drug that I talked about, 1 tablet once a day, is in global phase 3 trials all around the world to see if it can replicate these results. And hopefully it will do, and that will then lead to a 1 drug once a day regimen, which will be quite terrific. All right. The other thing to think about is, look, these are all new drugs. They may have side effects we don't know about. They may appear much after the clinical trials. What about looking at something as simple as just ribavirin in association with one of these new DAAs? And this is an NIH study which is phenomenally interesting because this is a study that was performed in urban Washington, D.C. These are predominantly African American patients. There's a high rate of obesity, high BMI. Many of the patients had advanced fibrosis, and they are brought in for treatment with sofosbuvir once a day plus ribavirin. Not an optimal regimen, but the overall cure rate was 68%. And with interferon-based therapies, these patients have significantly lower cure rates, and many of them can't tolerate treatment. So it shows that even in the harder to treat populations, these all-oral agents can make a major, major impact. So we also have in the US other genotypes, genotypes 2 and 3. And I want to just show you this data because this regimen is going to be approved relatively soon, we believe, by the FDA. And this is using sofosbuvir, the polymerase inhibitor, plus ribavirin. These are the results that we see. For genotype 2, the cure rates in naive patients are above 90%. For genotype 3, the cure rates are not quite as good. They're around 60%. So genotype 3 represents an issue and a problem. This is another study done in previous, again, naive patients, comparing sofosbuvir ribavirin to PEG and ribavirin. And again, genotype 2, 97% cure rates. So genotype 2 patients come next November can expect an all-oral treatment with a very, very high cure rate. And most of us are aware that our patients are asking for this. So again, very, very good. And finally, this is treatment failure patients looking at 2 different durations of therapy, showing that you can actually double the cure rates in genotype 3 by prolonging treatment from just 12 weeks to 16 weeks. So genotype 2, I consider a done deal, Tom. We're going to be able to cure 90% of them with a very simple regimen. Genotype 3 represents a challenge still because we're not at the 90% plus that we want to be, but we're going to get there. So these drugs are going to be available to us, and many of our patients are asking about them.
Do you want to give us the breakdown of those genotypes in the States and elsewhere?
Yeah. I think genotype 2 and 3 account for about 30% of our patients with hepatitis C in the US. Particularly, genotype 3 is very common in our younger IV drug users today. So about 20% overall Geno 3, about 10 to 15% Geno 2. So it is an impactful area for this treatment. So we're going to identify lots and lots of people with hepatitis C. Our colleagues in primary care and in internal medicine hopefully will create mechanisms to screen our baby boomer population. We're going to identify those people, and as one of our people who asked the question was, should we wait until we have these all-oral regimens? They're coming. The first ones will be here for genotype 2 and 3 before this calendar year is over, with a second wave coming through probably next year.
We're running out of time, Nid. I wonder if you'd like to summarize with the major...
Mm-hmm. And this is the major summary that we will have by probably 2015 all oral treatments. It could be 1 drug, 2 drugs, or even 3 drugs that will be able to be used for all patients with Hep C. We'll identify significantly more patients with hepatitis C. We'll be able to impact them not only in terms of cure, but also in terms of outcomes altogether. Ribavirin and interferon will be drugs of the past and will no longer be needed. And we are in the throes of a major hepatitis C revolution. We have terrific drugs being developed with major antiviral activity of all genotypes, no selection of resistance, all oral combinations, short treatment durations, even as short as 8 weeks for some of these treatments, once-a-day drugs, exceptional safety and tolerability. And right now, the future is very bright for hepatitis C patients. And I think that this illustrates why it's so important to make an attempt to identify our patients and eradicate this disease.
Thank you. I wonder if we're narrowing the focus of screening too closely on baby boomers. That's a slice of the population. Mm-hmm. What about people born after that time or have some burden of hepatitis C? Should we screen, are we going to screen everybody or stick to baby boomers?
I don't think we're going to screen everybody. So age-based screening should be baby boomers because the population is enriched. But that doesn't take away that you still have to do risk factor screening. So in fact, you have to do both. And the CDC are very cognizant that they don't want to miss the young people who have HCV. So, you know, lots of people born after 1965 have experimented with IV drugs, have been exposed, less likely so through transfusion, etc., but have been exposed to HCV. And they don't want to miss those, so they want us to continue with what's called risk factor screening. But the age-based screening is really for the baby boomer generation. But you're right, we don't want to miss the young people because we're still seeing lots of young people coming with hepatitis C.
The very interesting data that you showed us is among patients who are highly selected for a trial. In the real world, we know that there's a lot of people out there with metabolic syndrome, obesity, alcoholism, co-infection, etc. Are these drugs going to be expanded for use in all comers, do you think, or how do we select our patients?
So that's an awesome question, Tom. So one of the trials I showed you, positron, actually took people who were non-interferon-based candidates. So 45% had significant psychiatric comorbidities, depression, PTSD, things that we can't use interferon in. 20% had other autoimmune diseases that you can't use interferon in, and we had excellent results in that population. We have trials that are underway in almost every population you can think of. So we have trials that are taking place in prisons. We have trials that are taking place in methadone clinics. We have trials that are taking place in transplant situations with people with end-stage liver disease. Once we move away from interferon and we go all oral, you lose significantly the difficulty of having populations you can't reach. What's also very interesting, and I think this is a really important point, is that as you increase the potency of the all-oral regimens, so some of those ones I showed you, you actually take away all the predictors. So obesity is no longer a predictor. Doesn't predict outcome. Metabolic syndrome doesn't predict outcome. African American race, the biggest predictor for interferon responsiveness, doesn't predict outcome. IL-28B, the genetic predictor of response to interferon, doesn't predict outcome. All of these things, once you get cure rates above 90%, none of these things matter anymore. The only thing matters is that you take your tablets. And so the big thrust of this is going to be all about education and compliance. So it's not even going to be a disease that necessarily needs specialists to treat. It's something that's very similar to when HIV meds first came out. We had fantastic ID and internal medicine doctors focusing on HIV and treating them in the community. I can foresee a time where the majority of patients with hepatitis C are treated by their primary care doctors. If we've got an 8 to 12 week one drug once a day regimen, why do they need to see me? I only need to see those who have advanced liver disease or who have risks for cirrhosis and stuff. And I'm very eager that our internal medicine primary care community embrace this so that they can be involved in not just the screening but also the treatment.
Perhaps you'd mention the ECHO trial or the ECHO idea of having practitioners all over the state centralized into a...
So Dr. Sanjeev Arora in New Mexico, which has a reasonable burden of hepatitis C, developed a program called ECHO. And in this program, which again was published in the New England Journal, he was able to reach out to rural sites throughout New Mexico and create internal medicine doctors who could manage hepatitis C. And it was a hands-on education. So it's a linkage where they're linked in to a central place at the University of New Mexico, and they're able to discuss patients and in real time treat them, deal with their side effects. And people who'd never used complicated regimens involving interferon were able to do it. We have adopted the same thing here in Massachusetts. And we now have patients down on Cape Cod, 120 miles away in Provincetown, being treated by local primary care doctors down there with much more complicated regimens than these. And by this using telemedicine interlinking, we're able to do this. And what we really need to do now is really create the paradigms that enable primary care doctors to feel comfortable treating liver disease patients. And they're really quite simple, Tom. So we're working on this.
One thing I'm sure some people in our audience are thinking about is cost. We're entering a time when there's going to be cost containment in medicine for everything we do. I have the idea that these drugs may be expensive, and do you have any idea what we're facing here?
Yeah, I think these drugs will be expensive. Again, I have no idea what the price is because none of them are available yet. But let me change that around a bit and talk about what the cost is today. So we know this actually. We've done some cost analysis studies where we've looked at the true cost today of treating somebody with hepatitis C. And the way you do it is you look at cost per cure. So what you're really interested in is by curing patients, because treating somebody and failing, you have no benefit. So the cost per cure, based on some data generated from Mount Sinai for the current interferon, ribavirin, boceprevir, telaprevir regimens, was around $190,000 per cure. That's a huge cost. So, and that's looking at cure rates in around the 50 to 60% range. We've done the same thing at the BI, and actually we're in and around the same ballpark. So then we look at what these drugs can do. You can cure 90+% of people. The treatment duration is short. The side effect profile means they don't have to worry about other concomitant medications, admissions to hospital, etc. So the cost is just the cost of treatment. They don't even miss work. So there's no indirect costs attached to this. And so I think what we're going to see is when we know what the price is, we're going to see a plethora of highly cost-effective analyses come out, showing that, at a cost of, I'll throw out a ballpark for you, $65,000, that it's highly cost-effective to treat patients at that price.
Yes. Here's a practical question from Dr. Linda Hunt. Are you vaccinating Hep C patients with Hep A and Hep B vaccines or anything else?
Absolutely. So Hep A, Hep B vaccination is mandatory for our Hep C patients. So that's another reason why you should screen today, because they should be vaccinated for both of those two viruses. Highly effective vaccines are available. And for those with cirrhosis, we're also obviously vaccinating for pneumococcal vaccine.
Would you comment on the following question? Should patients with hepatocellular carcinoma be screened for Hep C, and what is the treatment modality?
So there is an epidemic of hepatocellular carcinoma in the U.S. today. It's really the fastest growing cancer in the United States. It's doubling every 5 years. And the reason for this is hepatitis C. As our population with hepatitis C ages, that more of them develop cirrhosis, and then as more develop cirrhosis, more develop liver cancer. So if you look at the cause of hepatocellular cancer in the U.S. today, 40% of patients have Hep C. So it's the commonest cause of HCC in the U.S. today. So obviously, if somebody presents with HCC, you need to rule out hepatitis C as a cause. This is the worst scenario. What we need to be doing is identifying these patients, treating them so that they don't get hepatocellular carcinoma. Because if you prevent development of cirrhosis, or you even get rid of the virus, you significantly reduce the chance of developing hepatocellular carcinoma.
Dr. Olga Ali has a question about decompensated patients. Can we treat patients with how far can we go with advanced cirrhosis using drugs like this?
We can probably go all the way. There are clinical trials underway in people with very advanced liver disease, including patients with Child's class B and C cirrhosis, high MELD scores, pre-transplant. We're also treating patients post-transplant with some of these combinations of treatment. And again, when you take interferon out of the mix, your ability to treat patients really expands. So populations that we had great difficulty with, the biggest population is advanced liver disease pre-transplant. That population is now being addressed for the first time, and that's fantastic.
Dr. Fayed has a question regarding diabetes. Is there any difference in outcome for Hep C patients with and without diabetes mellitus with these regimens?
No, diabetes doesn't make any difference in terms of response rate over what we've seen so far. We'll obviously need a bigger patient set to feel 100% comfortable saying that. You know, diabetes and HCV are like a hand and glove. So hepatitis C is strongly associated with diabetes, and hepatitis C promotes insulin resistance. Eradication of HCV often will improve diabetic control in many of our patients, and is a very important aspect of actually treating these patients.
Dr. Catherine Miller asked, do you think these promising new therapies will diminish the need for liver transplantation?
I wouldn't recommend too many people going into transplant surgery today. I do think they will diminish it significantly. Hepatitis C accounts for 40% of transplants today. If we impact the disease as we expect to, that effect won't be seen for 5 to 7 years, but 5 to 7 years down the line, we should see a marked decline in transplantation for HCV-related disease. It takes that long to actually take people off. You know, I give you a corollary to this. When the new drugs came out for hepatitis B, adefovir, tenofovir, and tecovir, hepatitis B was actually a common cause of liver transplant, Hep B-related liver failure. When the drugs came out that were able to suppress hepatitis B virus, hepatitis B now accounts for less than 100 transplants per year for liver failure in the United States. So you really, really impact disease when you can suppress these viruses.
Finally, with all this treatment of patients with Hep C and screening and so forth, some doctors have sent in questions. What do you do if you stick yourself with a needle from a patient with Hep C?
Yeah, that's a great question. So the first thing you do is don't panic. All right, the HCV transmission rate is 0.3%, even if you stick yourself with a highly infected, high viral load HCV patient. It's phenomenally low. And you do exactly what our people suggest, which is go wash it out, go get tested for HCV antibody to make sure you're negative, and then follow for HCV RNA at 4 weeks and 12 weeks. These new drugs will treat acute HCV highly effectively because acute HCV is really easy to treat. And so we don't have any strategies for prophylaxis, and it's highly unlikely that we're going to do it with such a low transmission rate. But clearly what will happen is that these will be used for acute HCV as well.
Thanks very much. I'd like to thank Shire, Viropharma Incorporated, UCB Inc., and Ferring Pharmaceuticals Inc. for the support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for the next session, Recent Advances in GI Endoscopy, What the Primary Care Physician Needs to Know, by Dr. Ram Chaitani. My name is Dr. Tom Lamont. Thank you for joining us.